Hello and welcome to the Palliation lecture in the Psychosis series. This is Dr. Nicholas Hatcher, and in this presentation we will apply psychopharmacologic and psychotherapeutic principles in the management of psychosis. Here's a reminder of where we are in the series. This lecture will emphasize the non-pharmacologic principles of psychosis management. In the 1970s, the recovery movement changed the approach to individuals with enduring psychotic illness. This movement resulted in a change from a primary role of reduction or elimination of symptoms to incorporate the recovery of functional capacity in several domains. This involved a change from provider-directed care to a more self-directed, person-centered, and empowering approach. Management was then expected to be nonlinear, incorporating management principles surrounding minor setbacks. In the spirit of this movement, the Substance Abuse and Mental Health Services Administration, or SAMHSA, described 4 dimensions of recovery. The first is the ability to overcome or manage one's illness. The second is a stable place to live. The third is meaningful daily activities and resources to participate in society. And the fourth is relationships and social networks. The goal became the development of comprehensive recovery plans. A recovery plan should include interventions directed toward reducing symptoms of disease, reducing disease and treatment burdens, and promoting health, wellness, optimal functioning, and quality of life. The Schizophrenia Port recommendations highlight 6 evidence-based psychosocial treatments. They include skills training, supported employment, cognitive behavioral therapy, behavior modification, social learning or token economy programs, and assertive community treatment. These elements are incorporated into this general recovery plan shown here. Please note that the recovery plan requires a multidisciplinary approach, recruiting the help from nurses, medical and psychiatric providers, case managers, and psychotherapists, among others. Psychosis management can be broken down into 4 phases: the acute phase, the maintenance phase, the health promotion phase, and the evaluation phase. We will explore each of these phases in more detail. Let's first look at the acute phase. Note that as we move through these phases, my primary emphasis will be on psychosocial interventions. For details on the psychopharmacologic principles of psychosis management, see the dedicated lecture to that content. Throughout the implementation of various psychosocial interventions, it is important to bear in mind the Therapeutic Alliance. There is a strong link between the Therapeutic Alliance and treatment outcomes. It is the single strongest variable determining therapy success. The Therapeutic Alliance is not just a byproduct of symptom improvement. Be sure throughout the alliance to attend to any ruptures and repair the alliance. In some studies, it is evident that the Therapeutic Alliance is likely more important than the specific modality of treatment incorporated. Here I've listed some of the qualities of a good therapeutic alliance. These include the following: mutual trust, respect, and caring, a general agreement on goals and tasks of therapy, shared decision-making, mutual engagement in the work of therapy, the ability to talk about here and now aspects of the alliance, the freedom to share any negative emotional responses to each other, and finally, the ability to correct any problems or difficulties that may arise in the relationship. The first step in any approach is to elicit the story. Explore current thoughts, feelings, and behaviors, as well as recent and distant past, and determine the current level of safety, particularly in regards to self or other directed harm. It's important to explore the past from a biopsychosocial perspective, thinking at all times, what are biological or genetic factors, psychological factors, and social factors that may be contributing to the patient's presentation and current state. Use PI to develop a better clinical picture. This mnemonic stands for problems, interventions, and evaluation. While eliciting the story, use chain link analysis, listen, validate, and reflect. Chain link analysis involves drawing connections between cause and effect situations. Where has this occurred in the past? Does this reflect the individual's current chain? What patterns emerge? While listening, consider both how you listen as well as what you are listening for. Validation is the first and most effective therapeutic technique for emotion dysregulation. Validation comes in 6 levels. I will share these levels in the next slide. Use reflection in order to choose where to intervene, as well as how ready the patient is for that intervention. Here I've listed the founder of dialectical behavioral therapy, Marsha Linehan's 6 levels of validation. In my DBT training, I learned to use validation profusely. Using validation is not only good for strengthening the Therapeutic Alliance, but is also a therapy technique in and of itself. While listening to the patient's story, aim for the highest level of validation you possibly can and use it liberally. If there is a safety concern, this must be addressed first. 2 questions should guide the initial approach. Number 1, is there a risk of self-directed harm? And number 2, is there a risk of other-directed harm? If the answer to either of these questions is yes, then the goal becomes establishing safety for the patient and others. If there is a risk of other-directed harm, then the patient may require management in a safe environment. This may include a crisis center, a hospital including emergency department or inpatient unit, or psychiatric hospitalization. If there is a particular target of the other-directed harm, then the healthcare provider is obligated by law to notify appropriate authorities, as well as the patient's target. This falls under duty to warn. De-escalation techniques should be implemented here to reduce the risk. It is always most appropriate to first attempt de-escalation with non-pharmacologic means. It may be that removing the patient from an environment with high stimuli will result in a rapid de-escalation. The general approach to these individuals should be gentle and calm, and emphasizing dealing with emotions. As I mentioned in a previous slide, validation of emotions is an effective technique. It is also not the time to process delusional or hallucinatory content, but at the same time it's important to not go along with the delusion or content of hallucinations. Oral or IM medication may be necessary if de-escalation techniques are ineffective and there is still a risk of other-directed harm. If there is a risk of self-directed harm, including suicidality, then the goal becomes establishing safety as well. As with other-directed harm, individuals at high risk for self-directed harm may require management in a safe environment. In this environment, there should be removal of any potentially harmful objects. The patient should never be left alone when acutely suicidal. Hospital settings often have protocols for 1-to-1 or 2-to-1 nurse-to-patient ratios and eyesight monitoring, among other things. During this time of monitoring, offer the self, allowing the patient to express thoughts, feelings, and antecedent events leading to suicidality. Throughout this process, address any needs that may arise and assist in dealing with emotions. As previously described, validation can be a very effective method for reducing affective charge. Work on the construction of an anti-suicide plan that includes who will be notified if suicidal thoughts arise, what coping skills can be implemented during this time, and what to do if these coping skills are ineffective. One of the most important variables to consider in suicidality is time. Suicidal thoughts and the underlying emotion are temporal in nature. The work of therapy then becomes a matter of what tools and techniques can be implemented to bridge the patient from the time that they are experiencing suicidal thoughts to a time at which they are not experiencing suicidal thoughts. Here I have 10 steps for working through delusions. The 10 steps are as follows. Number 1, place the delusion in a time frame and identify triggers. Number 2, assess the intensity, frequency, and duration of the delusion. Number 3, identify the emotional components of the delusion, emphasizing process over content. Number 4, observe for evidence of concrete thinking. Number 5, observe speech for symptoms of a thought disorder. Number 6, observe for the ability to accurately use cause and effect reasoning. Number 7, distinguish between the description of the experience and the facts of the situation. Number 8, carefully question the facts as they are presented, as well as their associated meaning. Number 9, discuss the consequences of the delusion when the person is ready. And number 10, promote distraction as a way to stop focusing on the delusion. For further elaboration on these 10 steps, please review my written supplementary material for this lecture. Some of the barriers to working with delusions include the following: becoming anxious and avoiding the person, reinforcing the delusion, attempting to prove the person is wrong, setting unrealistic goals, becoming incorporated in the delusional system, failing to clarify confusion surrounding the delusion, being inconsistent in intervention, and finally seeing the delusion first and the person second. The following are techniques to help work through hallucinations. Number 1, establish a trusting interpersonal relationship. Number 2, assess for symptoms of hallucinations, including duration, intensity, and frequency. Number 3, focus on the symptom and ask the patient to describe what is happening. Number 4, help the patient manage hallucinations. Number 5, identify whether drugs or alcohol have been used. Number 6, if asked, point out simply that you are not experiencing the same stimuli. Number 7, suggest and reinforce the use of interpersonal relationships as a symptom management technique. Number 8, help the patient describe and compare current and past hallucinations. Number 9, help the patient identify needs that may be reflected in the content of hallucinations. And number 10, determine the impact of the patient's symptoms on activities of daily living. Here are some additional considerations. Some of these have likely been mentioned in the context of previous interventions. In the management of hallucinations and delusions, it's important to offer the self, establish and maintain a therapeutic alliance, and do not leave the patient alone. Talk to the person using name, short and simple sentences, speaking loudly enough to get the patient's attention. Remain in the line of sight while maintaining gentle eye contact. Touch the patient only with permission. Now we will move into the maintenance phase. Interventions that focus on teaching self-management of symptoms and identifying symptoms indicative of relapse are most useful in the maintenance phase. Relapse occurs in these 5 classic stages. Stage 1 is overextension. In this stage, the patient complains of feeling overwhelmed, symptoms of anxiety are intensified, and great energy is used to overcome them. Patients describe feeling overloaded, describe being unable to concentrate on or complete tasks, and tend to forget words in the middle of sentences. Other symptoms include increased mental efforts to perform usual activities, decreasing performance efficiency, and easy distractibility. Stage 2 is restricted consciousness. In this stage, the previous symptoms of anxiety are joined by symptoms of depression. The depression is more intense than usual daily mood variations. There are added dimensions of appearing bored, apathetic, obsessional, and phobic. Somatization may occur. The patient seems to withdraw from everyday events and limits external stimulation as a way to protect against the upcoming loss of control. Stage 3 is disinhibition. The first appearance of psychotic features occurs in this stage. Symptoms may resemble those of hypomania and usually include the emergence of hallucinations and delusions that the patient is no longer able to control. Previously successful defense mechanisms tend to break down. Stage 4 is psychotic disorganization. In this stage, overtly psychotic symptoms occur. Hallucinations and delusions intensify, and the patient ultimately loses control. This stage is characterized by 3 subphases. The first subphase is destructuring of the external world. Here the patient no longer recognizes familiar environments or people, and may accuse family members of being imposters. Extreme agitation is possible. The second subphase is destructuring of the self. Here the patient loses personal identity and may refer to oneself in the third person. In the third subphase, there is total fragmentation, which refers to a total loss of the ability to differentiate reality from psychosis. The patient experiences complete loss of control. Hospitalization is usually required at this point. Stage 5 is psychotic resolution. This stage usually occurs in the hospital. The patient is generally medicated and still experiencing psychosis, but the symptoms are quote-unquote quiet. The person may appear to follow instructions in a robotic manner and often looks dazed. In addition to educating the patient and family about the stages of relapse, consider the following as part of the educational plan. Describe psychosis. Identify the causes of psychotic disorders. Define schizophrenia according to the symptoms and diagnostic criteria. Describe the relationship between anxiety and psychotic disorders. Analyze the impact of living with hallucinations. Analyze the impact of living with delusions. Discuss the use of psychotropic medications. Describe the characteristics of relapse and the role of compliance with the therapeutic regimen. Analyze behaviors that promote wellness. Discuss ways to cope adaptively with psychosis. Here I have listed several symptom management techniques under distinct categories. In the following few slides, I will share a few mnemonics to help with working through crises and implementing distraction techniques that may be beneficial. The accepts mnemonic is derived from dialectical behavioral therapy. This mnemonic includes skills to help with keeping an individual busy and distracting from preoccupation with crisis. A is for activities. Plan activities that keep you busy and involved. C is for contributing. Do something for others and journal about thoughts and feelings afterwards. The next C is for comparison. Draw healthy comparisons between yourself and other people. E is for emotions. Do something that creates other emotions, as emotions can flow from what we do. P is for pushing away. Put problems on hold for a period of time. For instance, this is a tomorrow problem. T is for thoughts. You can't think about 2 things at once, so direct thoughts towards something helpful. Read, watch an engrossing movie, do a crossword puzzle, etc. S is for sensations. Distract yourself with healthy sensations such as aromatherapy, listening to music, taking a hot or cold bath, etc. The improve mnemonic is also derived from dialectical behavioral therapy. This mnemonic includes skills to help make a crisis more tolerable when remaining present is necessary. I is for imagery. There are several available techniques for imagery and downloadable applications to help with this as well. M is for meaning. According to Viktor Frankl, if there is a why, then a person can figure out the how. List and contemplate your whys for working on any issue in life. Meaning motivates. P is for pause. Pause and be still for a moment, allowing for connection and serenity. R is for relaxation. Take a moment to be mindful of your breathing, to tense and release your major muscle groups, or to simply sit in a quiet place. O is for one thing or moment at a time. Do only one thing in this moment. When we open up too many applications, or in other words, do too many activities at once, we slow down or crash just like our electronics. Pick the application you want and do that one activity. V is for vacation. Take planned breaks from your crisis or other stressors. And finally, E is for encouragement. Coach, cheerlead, and affirm yourself with positive self-talk. Take time to write down 5 to 10 statements you can practice. In teaching effective symptom management, the following should be considered. Number 1, identify problem symptoms. Number 2, identify current symptom management techniques. Number 3, identify specific support systems. Number 4, discuss additional symptom management techniques. Number 5, eliminate non-productive symptom management. And number 6, develop a new symptom management plan. Now we will review the health promotion phase. One of the keys to preventing relapse includes identifying symptom triggers and strategies for managing them. A recovery-oriented approach provides significant improvement in functioning and coping skills. Here I've listed 4 programs. These include the 3 R's Psychiatric Rehabilitation Program, Lieberman's Skills Training Program, McFarland's Family Education Program, and finally the National Alliance on Mental Illness, or NAMI, Family-to-Family Program. Another aspect to health promotion is maintaining physical health. The pleased mnemonic, derived from dialectical behavioral therapy, can be an effective tool to recall good health maintenance skills. P stands for physical health and involves maintaining regular physical checkups and attending to medical illnesses. L refers to listing resources and barriers for each part of the acronym. E refers to eating healthy foods in a balanced way. A refers to avoiding drugs and alcohol. S refers to sleeping enough to feel good. E refers to exercising daily. And D is a reminder that daily practice makes the difference. In this final section, let's explore questions to guide evaluation of the plan of care. Questions guiding the evaluation of the plan of care are as follows. Number 1, are the core symptom clusters of the disease improved? Number 2, is the treatment burden reduced with limited side effects and long-term health risks? Number 3, has the burden of illness been decreased by enhancing adaptive and functional skills and minimizing family burden? Number 4, have health and wellness been promoted? Number 5, is the patient able to describe the behaviors associated with the onset of a relapse? Number 6, is the patient able to identify and describe the medications prescribed, the reasons for taking them, the frequency of taking them, and possible side effects? Number 7, does the patient participate in relationships with other people? Number 8, is the patient's family aware of the characteristics of the illness and supportive of the patient? And number 9, are the patient and family informed about available community resources such as rehabilitation programs, mental health providers, educational programs, and support groups, and do they use them? For downloadable content such as written notes, PowerPoint slides, and more related to this lecture series, please visit my website using the link below. You can also support my goal of continuing to provide new content through Patreon, where becoming a patron will provide you with access to downloadable content as I create new content. Thank you for your support. Here are my references for this presentation. Thank you for listening.